All right, it's 11 o'clock, so let's get started. This is a very exciting session, and I'm excited to welcome you all to the top 4 research abstracts from all of the abstracts that were submitted for presentation at this conference. So I'll call up to the stage our first presenter, Dr. Waleed Alqurashi from the University of Ottawa.
Good morning, everyone, and thank you for being here on the last day of the meeting. I would like to thank CAPE for giving me the opportunity to present our trial, the prepared trial for anaphylaxis. It's an observational study. I have no conflict of interest except for receiving funding for this trial from CHR and Ontario Innovation Fund and CHIU Research Institute as well. This study also received in-kind support from PERC as well as Food Allergy Canada. So the main question this study is answering is post-observation for anaphylaxis. And this is a question we struggle with all the time, for how long to keep those patients and who I need to keep. So there is a wide practice variation and really ranges from people who observe unnecessarily for a long time and people who send patients too early home. This is essentially the question we wanted to answer. So the objectives of this study is we wanted to describe the epidemiology of biphasic anaphylaxis, to derive and internally validate a prediction model, and to derive a risk stratification score that we can apply at the time of discharge. This was a multicenter study, prospective observation study across 7 PERC sites. We've enrolled 1,686 children over 3 years, and the primary outcome was anaphylactic biphasic reaction. To be eligible for the study, you have to have an anaphylactic reaction meeting the World Allergy Organization criteria, and the participant have to be proficient in English or French. We excluded any reaction that happened within hospital or in a context of suicidal attempt, or if the participants are unable to complete the follow-up after discharge. How did we define the anaphylactic biphasic reaction? Essentially, if you have patient had an anaphylactic reaction, followed by a second phase of at least 1 hour of symptoms-free period with no treatment, followed by a second phase where they have signs and symptoms that meet anaphylaxis criteria that are not caused by antigen re-exposure. We have also the other outcome, what we call severe anaphylactic biphasic reaction. This is kind of a subtype of anaphylactic biphasic reaction, which is a severe type. And the severe means they have to have any of those criteria. The second reaction is treated by more than 1 dose of epinephrine, or if they needed admission for the second reaction to PICU, or if they have cardiovascular sign. Cardiovascular sign is specifically hypotension, syncope, or altered level of consciousness. So if they meet any of those criteria, then that second reaction, we call it severe anaphylactic biphasic reaction. To have a really comprehensive data on this study, we essentially approach patients when they arrive to ED. We ask them everything about the reaction, some demographic data, and then while they are in ED, the research assistant checked on them every 2 hours to see if a reaction happened, and if the reaction happened, they would have to confirm that with the treating MD. After discharge, the research coordinator would review the chart to collect data from the chart about treatment, and signs and symptoms in ED. And when the patient discharged, like 2 to 5 days after discharge, we follow up with the patient to inquire about, if there was a biphasic reaction happened after discharge. The data was analyzed using regression model, and we use assess for performance measure using discrimination, calibration, and clinical utility. We also did an internal validation using internal strap, and we assess for overfitting and fix for overfitting using uniform shrinkage. So in terms of the results, this is the flow of the study. So over the 3 years period, over 2,700 patients were screened. Almost 1/3 of them were excluded, primarily for not meeting anaphylaxis criteria. At the end, we have 1,686 children. 95% of them completed the follow-up. In terms of baseline characteristic, one thing noticeable is patients who had anaphylactic biphasic reaction were generally older in terms of age, and there are also more proportion of female patients within that group. Also, within the anaphylactic biphasic group, patient who had an unknown trigger, I mean, they are likely to be within that anaphylactic group. For the epidemiology of anaphylactic biphasic reaction, so among all the participants, 13% had biphasic reaction. So the 13% include anaphylactic and non-anaphylactic. The primary outcome, which is anaphylactic biphasic reaction, that's constitute around 6.8%. Interestingly, half of those reactions happened after patient was discharged, so happened at home. And almost half of those who had a reaction after being home, they end up actually coming back to ED. In terms of the final model, we have, as per protocol, 18 predictors. I'm not going to go all over them. You can scan the QR code and to see actually the published protocol. At the end, we have eight predictors in the model. So in terms of the definition, I just want to highlight a few things here. So for cardiovascular sign, we're talking about hypotension, syncope, or loss of consciousness. For respiratory sign, we're talking about wheezing, respiratory distress, stridor, or accessory muscle use. For the trigger, it's either unknown trigger or known trigger. So it doesn't matter, if it is food, but the specific food is unknown, that is still considered a known trigger, just so that we're clear on what known and unknown means. This is the final model with the odds ratio. You can see age, cardiovascular signs, and other signs are significant predictors of biphasic reaction. In terms of the internal validation, the calibration, the most important part of the model performance is the calibration. So the apparent calibration was almost perfect, which is 1, but that is too good to be true. So that's why we have an internal validation, which still shows, a pretty good internal calibration. We use that internal calibration, an internal validation process to come up with the optimization or a shrinkage factor to adjust for the odds ratio in the final model. I'll skip this slide. So beyond discrimination and calibration, the other thing we will assess for is the clinical utility. So we wanted to know if this model is actually implemented, does it actually improve decision making? So this is what's called clinical utility or decision curve analysis. On the y-axis, you see the net benefit, and on the x-axis, you see the threshold where physicians typically use different thresholds to make a decision. The perfect model or the ideal model would be which has a net benefit where it is above treating none, and also positive has a positive net benefit, which we see in this the green line there. It shows the model has actually positive net benefit. Now, how does that compare with the actual physician practice? So we compared the model with how currently physicians actually make decision. And the model has a much better and a positive net benefit. In fact, current practice is harmful in a way that is under higher threshold. You see physician making decision for more admission, while in the lower threshold, it's essentially like you're treating everyone the same. So the model is much better in terms of stratifying patients. For the stratification, we divide them into 4 categories. It goes from the very low to a high. And as you see, the higher the risk, the higher the probability of the event. When we looked at the time, because that was the initial intention, is to come up with some sort of a clear timeline. The time of anaphylactic biphasic reaction is really shown to be completely useless. Because while the median time is pretty much close, regardless of the risk score, the risk group, the range is pretty high. So that is, we found that to be useless. And that's why we use severe anaphylactic biphasic reaction as an alternative, a better outcome. Those are the patients you actually worry about them if they have, anaphylactic biphasic reaction. So you can see there in the low-risk group, in the very low-risk group, there is 0 event. And in the very high or the high group, the probability of having that event is around 16%. In terms of the timeline of having a severe anaphylactic biphasic reaction, the median time, contrary to one might think, actually the higher the risk, the later the onset, which doesn't make sense, from the, how the body works, but this is what we found. The range is pretty wide, but the median is, the higher the risk, the higher the median time. So if we apply that into an actual decision rules, in the very low risk group, those patients can be discharged within 2 hours. That is from the last epinephrine treatment. And this is a shared decision making based on the time that they had the severe anaphylactic reaction. And again, the time goes up as the risk goes up. For the high-risk patients, the ideal decision-making would be admitting those patients because the median time for having those events is around 19 hours. So it doesn't make sense to keep those patients in ED. And in fact, by following this, it actually reduced the current admission rate by almost 50% because the existing current admission rate is around 4%. And if we use this rule, it will reduce that by around 2%. I'll just go over to the last slide. So in conclusion, this is the largest prospective study done to date in anaphylaxis, and we found 7% of patients had anaphylactic biphasic reaction. Almost half of those patients had their reaction after discharge. The main limitation of this study is really the lack of external validation, so that will be the next step in terms of where we're going forward. We were also not able to model the time from the epinephrine treatment to the event, which is the biphasic reaction. I would like to thank the huge team that contributed this study. I could have not done it without their help and their support. And that will be my last slide. Thank you very much for your time.
So thank you very much for this excellent work. Thanks so much and congratulations. I think we have time for maybe 1 or 2 questions if anyone in the audience has a question. All right. And if not, I'd be curious to ask you, your model ended up being based entirely on factors from the emergency department, all of your predictors. Did you take a look at anything that was patient-reported or perhaps EMS reported prior to arrival?
Yeah, so that's an excellent question. I think, okay, that's fine. So we looked at the signs and symptoms from reported by patient at triage and in ED, and we actually found signs and symptoms reported patients are actually not predictive of biphasic reaction. They could have a severe respiratory distress, hypotension. If it happened pre-hospital, it really doesn't matter. What matters is how they look when they are presenting in ED. So that was an interesting finding.
So, Waleed, great work. Congratulations. It's Jeff Perry from the University of Ottawa. Just a couple of questions. One was your follow-up rate for your kids. How complete was it?
95%.
Fantastic. That's outstanding. And then the next question is in terms of next steps, are you going to plan to do an implementation study and see how this works prospectively going forward in time?
Yeah, I think before we go into implementation, we would love to do an external validation first, and then we'll go through the implementation process.
Okay, great work.
Thank you.
All right. I don't think I see any other questions. Wonderful. Congratulations.
Thank you.